Welcome to the Deep Dive. Today we're getting into something really critical in the ICU. Severe rhabdomyolysis when it hits the kidneys, causing acute kidney injury, or AKI.
Yeah, it's a situation we unfortunately see quite a bit, and its serious mortality can be really high, sometimes over 60%.
And a lot of these patients end up needing renal replacement therapy, right? RRT.
Oh,
That's really where today's discussion is focused.
exactly. The big problem is myoglobin. It's released from damaged muscle. It's pretty big, about 17 kilodaltons, and, well, standard dialysis just doesn't pull it out very effectively.
So we're looking at a study that compares two, let's say, more advanced ways to tackle this myoglobin issue.
That's right. The first is continuous veno-venous hemodiafiltration, CVVHDF, but using a specific high-flux filter, the HF80.
Okay, high flux meaning bigger pores in the filter.
Yes. And the second option they looked at was combining standard CVVHDF using a different high-flux filter, the F60S, with something called a CytoSorb adsorber.
Right, CytoSorb. That's a device that kind of sponges up specific molecules from the blood. Initially for cytokines, but it grabs myoglobin too.
Precisely.
In this study, it's a retrospective look, isn't it? Single center?
Yep, single center. They compared patients treated with the HF80 method between 2010 and 2016.
Against those who got the cytosorb combo more recently, between 2018 and 2023.
So our mission here today, especially for you in critical care, is to really understand what this study found. How well did these two methods actually remove myoglobin?
And crucially, did that make a difference in how patients did? You know, survival, kidney recovery, that sort of thing.
Let's dive in.
Okay, so the patients, two groups. HF80 had 97 patients, CytoSorb had 102. But importantly, this being retrospective, the groups weren't identical at the start, were they?
No, and that's a really key point. Table 1 shows these differences. For instance, the CytoSorb group, they had a higher median SSCS2 score.
SAPS2, that's a severity score, right?
Yeah.
Higher score means sicker patient, higher risk.
Correct. But interestingly, the HF80 group actually had more treatment sessions on average.
And the causes of the rhabdo differed somewhat too.
Yeah, significantly more aortic dissection or aneurysm ruptures in the HF80 group, whereas the CytoSorb group had more cases after cardiac surgery.
Also, initial CK and myoglobin levels, the markers for muscle damage, they were higher in the HF80 group.
Significantly higher, yes. And more patients in that HF80 group were already on dialysis before starting the specific treatment being studied.
Okay, so we need to keep those baseline differences in mind as we look at the results. What about the main question, myoglobin reduction?
This is where it gets quite interesting, because despite the different approaches, the reduction was, well, pretty similar.
Similar? How similar?
After 24 hours, the median reduction was 40% for CytoSorb and 39% for HF80, almost identical.
Wow. And longer term, say 72 hours.
Still comparable. CytoSorb group showed a 60% median reduction, HF80 showed 69%.
So statistically, no real difference between them.
Nope. No statistically significant difference in the relative myoglobin removal at either time point. Figure 1 shows this quite clearly. Even looking at the rate of removal, day 0 to 1 versus day 1 to 3, still no significant difference.
Okay, so point 1. Myoglobin clearance looks roughly equivalent in this study. What about CK, the creatine kinase? Did that follow the same pattern?
Pretty much, yes. CK levels dropped significantly with both treatments, especially by day 3.
And the amount of reduction?
Again, the relative percentage drop in CK was equivalent between the groups. No matter how they sliced the data, it came out the same. That's in figure 2.
All right, so markers down similarly. What about the patient's overall condition in the ICU? Did things like SOFA scores or SAPS2 scores improve differently?
Both treatments led to significant improvements in those scores from baseline to the end of therapy. You can see that in figure 3.
Any hint of one being better?
Well, visually, the drop looked a bit steeper in the CytoSorb group, but when they calculated the relative percentage reduction...
No significant difference again.
Exactly. No significant difference.
Okay. Now, for us managing these patients, kidney recovery is huge. Did more patients start making urine again with one treatment over the other? Diuresis return?
No. The proportion of patients regaining diuresis was comparable between the two groups. Table 2 lays this out.
Even if you only looked at the survivors?
Even just looking at survivors, the rate of diuresis return was similar. So on that front, they seem to perform equally well in supporting kidney function recovery.
Which brings us to the bottom line, really. Survival. Any difference in mortality?
This is often the toughest outcome to shift. And no, neither the 7-day mortality nor the overall in-hospital mortality rates were significantly different.
No difference at all.
There was a slight, and I mean slight, trend favoring the CytoSorb group for fewer deaths in the first 7 days, but it wasn't statistically significant. We can't really say it's a true effect based on this data. Figure 4 and Table 2 show those numbers.
So similar myoglobin clearance, similar CK drop, similar clinical score improvement, similar kidney recovery rates, and similar mortality.
Interesting. It is.
Yeah.
But they did dig a bit deeper, looking at subgroups based on how CK levels changed in the first 24 hours.
Okay. So comparing patients whose CK went down versus those whose CK went up early on.
Precisely. Does that early trajectory matter? They found a trend, again, not quite significant, suggesting that if your CK was decreasing in the first 24 hours, you tended to have slightly better myoglobin elimination, regardless of treatment group. That's figure 5A.
Makes sense. If the muscle damage is slowing down, maybe the clearance systems work better.
And more importantly, a CK decrease in that first 24 hours was linked to significant improvements in SOFA and SAPS2 scores later on. A CK increase wasn't.
Also logical. If things are still getting worse muscle-wise, the overall condition isn't likely improving rapidly.
Well, here's a really critical finding, I think. For patients treated with CytoSorb, if their CK increased in those first 24 hours, they had the worst survival rates. Significantly worse. That's a stark contrast shown in figures 5C and D.
Wow, okay. So that early CK trend seems particularly prognostic, maybe even predictive, in the CytoSorb group regarding survival. What about kidney recovery in those subgroups?
In the HF80 group, if your CK decreased early, you were significantly more likely to regain diuresis compared to those whose CK increased.
But not in the CytoSorb group.
That significant link wasn't seen in the CytoSorb group. Although, if you just looked at the patients whose CK did decrease, the rates of regaining diuresis were similar between HF80 and CytoSorb. It's subtle, but suggests the interaction between early muscle damage trends and kidney recovery might differ slightly depending on the treatment.
Fascinating nuance there. Okay, shifting gears, slightly long-term kidney function. End-stage kidney disease, ESKD. Any differences there for the survivors?
Among the survivors who made it to discharge, the frequency of developing new-onset ESKD was similar between the HF80 and CytoSorb groups.
And their kidney function at discharge, assuming they didn't have prior kidney disease.
Also similar. Their eGFR estimated glomerular filtration rate was comparable between the groups for those without pre-existing CKD.
But there was a connection between myoglobin clearance and ESKD, right?
Yes, a very important one, highlighted in Table 3. Survivors who did end up with new-onset ESKD.
Yes.
They had significantly lower percentage reductions in myoglobin at both 24 and 72 hours compared to survivors who became dialysis-free.
So less effective myoglobin removal was linked to worse long-term kidney outcomes.
Exactly. And this effect seemed particularly pronounced in the CytoSorb group. It really suggests that ongoing, poorly controlled rhabdomyolysis is a major risk factor for ending up with permanent kidney damage.
That really underlines that just removing myoglobin might not be the whole story. You got to stop the muscle breakdown itself.
Absolutely crucial point. Now, the authors rightly put their findings into context with other studies. This isn't the first look at CytoSorb for rhabdo.
Right. What's the bigger picture?
Well, some earlier, smaller studies suggested CytoSorb worked well, but often lacked control groups. More robust studies, like from Greff et al. And de Fallois et al., actually found results similar to this study, comparable myoglobin reduction between CytoSorb plus high-flux dialysis versus high-flux dialysis alone.
So this study kind of fits with some of the better controlled previous work.
It does, but then there's the whole issue of CytoSorb potentially getting saturated.
The filter filling up quickly.
Exactly. Other research and even expert consensus papers suggest CytoSorb's capacity for myoglobin might be limited. It could get saturated, maybe even within hours.
And in this study, they only changed the CytoSorb device every 24 hours.
Right. So the authors acknowledge this might have underestimated CytoSorb's potential. Maybe more frequent changes, especially early on when myoglobin levels are sky high, would make a bigger difference.
That's a key practical point for anyone using it. What about other filter types like HCO or MCO?
High cutoff, HCO, and medium cutoff, MCO dialyzers. They have even bigger pores. Studies suggest they can clear myoglobin more effectively than standard high-flux filters.
But downsides too.
With HCO, definitely. You can lose a lot of albumin, which isn't good. MCO filters might be a middle ground. Whitehawes et al. Did a pilot trial suggesting clearance might be similar across high-flux, CytoSorb with high-flux, and HCO in the first 24 hours. But they also saw CytoSorb's effectiveness drop off fast after the first hour, likely due to that saturation issue. Graf et al. Saw something similar.
So maybe combining CytoSorb with these other filters is the way forward.
Potentially. Albrecht et al. Did a pilot RCT suggesting CytoSorb plus HCO might clear myoglobin faster initially, and a simulation by Whitehawes suggested frequent CytoSorb changes with an HCO filter could keep clearance high. It points towards needing a tailored approach, maybe frequent changes early on.
But going back to kidney recovery, this study didn't find the benefit for CytoSorb that Graf et al. Suggested in their propensity-matched study. Why the difference?
Good question. The current study's authors suggest differences in study design, like including patients with pre-existing kidney disease or how long they followed. Patients could explain why Graf found improved kidney recovery, and this study didn't find a difference in diuresis return or kidney function at discharge. Different populations, different methods.
Okay. And the lack of mortality benefit here seems consistent with other studies, too.
Yes, Graf et al. And Disfellow et al. Also didn't find a significant mortality difference. The thinking is that these patients are often so critically ill from their underlying condition.
That just removing myoglobin might not be enough to change their overall survival odds.
That seems plausible. Plus, there's that lingering concern. Could CytoSorb be removing other things we want in the blood, like antibiotics? Could that play a role? It's speculative, but needs consideration.
And of course, we have to remember the limitations of this specific study.
Absolutely crucial. It's retrospective, relying on routinely collected data. It's from a single center.
And those baseline differences between the groups we talked about earlier.
Exactly. And importantly, no true control group getting just standard medical care without any extracorporeal therapy. So we can compare HF80 versus CytoSorb here, but we can't definitively say either is better than no advanced RRT based solely on this study.
Okay, so let's try and wrap this up. What's the main message for you, the listener, especially if you're in critical care?
I think the core takeaway is this. In this particular comparison, using a 24-hour exchange for CytoSorb, adding it to CVVHDF didn't seem to offer a significant advantage over using CVVHDF with the high-flux HF80 filter alone. Myoglobin reduction, clinical outcomes, mortality, kidney recovery at discharge, they all came out looking pretty similar.
So CytoSorb is a viable option. It removes myoglobin, but based on this evidence and protocol, it wasn't demonstrably superior to a good high-flux dialysis strategy.
Right. But that finding about CK trends is important. If CK is rising early on, especially in a patient on CytoSorb, this study suggests a potentially worse prognosis, particularly for survival. That really highlights the need for close monitoring of those muscle markers.
It definitely sounds like the debate isn't settled. We need more research.
Absolutely. Especially on optimizing CytoSorb. It's like, when and how often should we change the adsorber? Is combining it with HCO or MCO filters the key? These are open questions.
And they mentioned they're planning a future study on MCO filters with CytoSorb.
Yes, a prospective study, which should give us much better data. We'll be watching for that.
Which leads us nicely to our final thought for you to consider. Given all this talk about CytoSorb saturation, especially early on, could changing that adsorber much more frequently, maybe every few hours initially, particularly in patients whose myoglobin is shooting up fastest, could that unlock a benefit we just didn't see with the 24-hour changes used here? And beyond the device, what other patient factors, maybe the cause of the rhabdo or how fast it's progressing, should guide us in choosing between these different strategies for our critically ill patients? Something to think about next time you're faced with this challenging situation. Thanks for joining us on The Deep Dive.